Just wanted to request some of the doctors to come back on stage, which is Dr. Netravathi, Dr. J.D. Mukherji, and Dr. Rajesh Iyer. Please come back for the next session. And also we would like Dr. Mukul Varma from Apollo Hospital, Dr. Praveen Gupta from Fortis Hospital, and Dr. Pravar Passi from Indore. Please come on stage for your next session. Dr. Padma here from AIMS, from Paras Hospital requires no introduction. She is here and she will be moderating this next session. Thank you, Dr. Padma.
Thank you, MSSI. Actually, the energy and the passion that is palpable out here is really, really infectious. But tell me, you had a really exhausting session from, I think, the last couple of hours. How many of you are truly fatigued? Do you want a break? Or shall we go on? I do see half of the hall which has emptied out though. But then, I'm not going to talk about real science out here. Let me just, give you a little context setting. And this is a real life story. I have a patient, or I should say a young girl who's living with multiple sclerosis. She's been on follow-up with me in AIMS while I was there for a long time. She has had events on level 1. So we chose her to go on to level 2, and most of you know the level 2 disease modifying therapies. And because of the economic concerns, and I was there for the first session, in spite of whatever the insurance policies, whatever those humongous Amazonian advances which are taking place in the health infrastructure and healthcare delivery system, I don't believe this country has a health equity yet. We're still driving towards it, but getting down to the brass tacks, health equity is still a distant dream. Said that, therefore this girl chose to take a level 2, which was an oral medication, which was pocket friendly. She was on that medication, and then the COVID hit. And she got COVID. She lives in Padma. She actually came down, and then at that time in the COVID, she was admitted with bad pneumonia. In that time we had the trauma center which was converted into the COVID as hospital. She battled the disease. She was on a ventilator, and then because of that level 2 DMT, she was on an oral medication. She actually was diagnosed with PML. Now PML is progressive multifocal leukoencephalopathy, one of those bad things that can happen in when you have an aggressive thing. That, I don't know how many of you know about PML. It is one of those things which, you keep taking JC virus, you try and look at that. With that, then she was COVID negative. She was brought back to the neurology ward. We admitted her, and this was all during COVID time. And then we gave her plasmapheresis. She came out of it. It was a true battle. And then we discharged her. She went back to Patna. There's nothing very dedicated there happening, and for every time and for a lot of what happens, people do come back to a tertiary care center in a metro hospitals. So she came back, and let me tell you one thing, that she came for a follow-up about a couple of months back. Now I moved out of AIMS. I'm in a private sector in Gurgaon. This girl appeared for the civil services. Ladies and gentlemen, she qualified for civil services. And I think this is what defines, and I get choked, and I don't think I can talk on behalf of everybody out here. Nothing gives us more joy than this happening. And this is this young girl. Look at the grit, the determination, what Rohit was saying, the positive attitude. And I think, how many of people with MS has actually gone through what this girl has gone through? She was on a ventilator. She fought COVID. She fought PML. She was on plasmapheresis. She was sent home on a stretcher, and she comes back, fighting back, and she's now getting to get into civil services. She's qualified. So she still walks with a little limp. Now that doesn't deter her. Now this can happen to anybody. What I'm saying is, this outcome is possible. Now the thing I said this context is, MS is so heterogeneous. It is heterogeneous in, how it affects a person, how it behaves, what drug is best for one person as it is, whatever we have. I mean, there's so many advances. The thing is that we live in an infrastructure which is limited. We have limited resources. That is a reality we have to contend with. Said that, here we have someone who's coming from Bangalore. Rajesh is now in here, and Praveen is Gurgaon. Pravar is coming from Indore, and Dr. Mukul Varma is one of the biggest tertiary centers in Delhi. The question that I have, I start with, I don't know who I'm supposed to start with. I'm not going to keep it that very, it'll be shooting to anybody and everybody. So where is JD? JD's disappeared. Here he is. Oh, okay. So, okay. All right. Pravar, I'll start with you. Now, the best scenario will be that wherever you're working and wherever the person is stationed with will have the best infrastructure there to be able to deal with MS. Now, when I talk about infrastructure, I'm not talking about high-end efficacy therapies or a 7 Tesla MRI or a capability of doing NFL. What I mean is a holistic approach when a person with multiple sclerosis has walked into your clinic. So, what we call as MS clinic. What is the feasibility of setting up an MS clinic? You are in a private sector and you are in Indore. What is the feasibility and what would be the basic infrastructure or the basic tenets or what is mandatory to set it up?
So, I'm in a tier 2 city, Indore, which incidentally is also the cleanest city in India. So, I'm in private practice for the last 3 decades. So, in a private setup, it's a tad difficult to have a clinic of this kind, but in a government setup, it's absolutely possible because there is so much of staff and so much of manpower which is available. But I think some things which are absolutely non-negotiable for a MS clinic is you need a very good rehab team for these patients. You need a physiotherapist, you need occupational therapists, you probably need swallowing and speech therapists. They are completely non-negotiable. You need a social worker who can connect the dots for these patients and tell them that, look here, these are the insurance schemes, these are the things where you can get free drugs or subsidized drugs and stuff like that. And of course, at the center of everything is a neurologist. You need a psychiatrist in place as well. So, a common space, you need a social worker, you need a psychiatrist, you need a bunch of rehab people. You need a person to keep the data of these patients so that if something new comes up, if new drugs come up, or if there are new avenues for these patients, you can proactively call them or email them and tell them that, look here, this is available and why do you want to get on board on this trial or stuff like that. So I think that was my dream of how a MS clinic would work. And I always put myself in patients' shoes and see, if I can't offer that, what second best thing can I do to them? And I try and put many pieces of the jigsaw together and then offer them a kind of comprehensive care, which is not under one roof, but under one roof will be a lot better to have it.
True. So, well said. So, in fact, in AIMS, this was, I think, in 2019, and Rohit, I mean, I don't see him also. So, he was like, he bugged me. Then I had just taken over as the chief of the Center of Neurosciences, and he would say that multiple sclerosis, people living with MS need a different kind of an ecosystem to address their problems. It cannot be that 70 to 100 people in an OPD and I could just listen to them for a minute and write down something and send them. That's not the way it's going to work. Please get an MS clinic. And ultimately we started the MS clinic. He's a real pain in the ass when he wants to be, okay? So all of you know. So we did that. He's very passionate about multiple sclerosis, they think. And then subsequently even the MS registry. So the MS clinic, the whole concept was that there is a dedicated time given, and also in that space you also had this multi-speciality aspects, whether it is in terms of mental health, and we have the whole barrage or spectrum of mental health issues in MS for reasons more than one. And you also had a urologist or a nephrologist. You also had a physiotherapist with an occupational and the other aspects of it. And you had someone who was dealing with pain, and someone who could coordinate. So someone who had come now and say, now my disability is essentially, there's a high frequency, I keep getting urinary tract infections, I simply don't seem to be getting rid of this bug. And every time I'm in this multitude of antibiotics, and that sets, I can't even go on to a better, monoclonal antibody because of the infections. So how do I get rid of it? So then we say that, oh, okay, you go refer to urologist or whatever. The guy goes and gets an appointment for the lady, another hour, 2-3 months, and then also a space. Where am I going on a wheelchair? How do I find the space? And that is true, whether it is AIMS, it is NIMHANS, it is wherever these huge institutes are. Maybe NIMHANS is a little better. But certainly, these kind of mini cities that these big public sectors are, it's a challenge. Said that, setting up at an MS clinic doesn't mean that you have just that board of an MS clinic, but it also should have these necessary commodities and facilitate the access, availability, and also affordability to be able to be addressed to whatever the concerns are. So therefore, Netra, in NIMHANS, what kind of a progress has been done? I know you run an MS clinic. So what is it that you're doing there, and can it be provided as a blueprint for at least the rest of the public sector hospitals? I mean, I'm not talking of the private sectors because I'm also in your shoes now and I know what all problems we have there, but at least in the public sector hospitals, which can be, well, if not everywhere into the, the boondocks of the country, but at least in certain places. Please.
Thank you. I think it's an important thing to have a MS. We have a MS and NMO clinic, which is a dedicated specialty CNS demyelination clinic. So this we have every 4th Saturday of every month. So let me tell you from the scratch, it was not easy for me to start. It was literally, for nearly 3 years, I had to convince all the stakeholders, the administrators as to why it was required. Because if you actually go to any hospital, if any neurological problem is there, it's the headache, stroke, epilepsy, seizures. These are the most important and most common disorder, and they will give weightage to anything what you give. So if I go tell that I have a lot of patients with MS, I want a dedicated clinic. For them it is like, what is there, 3-4 patients for that, why you want to set up? So it took time for us to make them understand what was a need. So that nearly took for us 2 years. So apart from that, we have now a dedicated MS clinic, which caters to the patients or the people with MS and other CNS disorders. So we have a dedicated neurologist like me. There are other 2 neurologists who sit there, and we talk to them everything. So the patients know that apart from the other OPD days, they can come on this day. That time there is more time given, and you'll be able to sort out and give more dedicated time to the patient. We have our psychiatrists also who are sitting. So we have a clinic which has around 8 rooms in that clinic. So different specialities are there in all the other rooms. So neurologist, a psychiatrist, psychologist we have, psychiatry, social work. The social work people help in most of the caregivers as well as the UDID, as well as whenever any medication has to be given or any financial thing has to be covered, they are there. Physiotherapist, speech therapist very less, but physiotherapist yes. We have orthotist we have, as well as apart from that we also have a yoga and integrative. So these are the things which we have set up. We don't have 2 specialities in our hospital, that is the urologist and the ophthalmologist. That is because ours is a neuropsychiatry hospital. So these 2 specialities are not there, but they come on a different days, and so we make them sure that these people cater to those. So apart from these, we should have all these urologists, ophthalmologists, and dedicated team. And before we have a team, it shouldn't happen that I am talking something, my psychiatrist is talking something else. We all need to be on the same page. Otherwise, the patient is going to get confused because I'm going to tell, take this as well as some other person is going to tell, take something. So it becomes important for us to address all this. So all of us are in the same page. That is not easy because each of them are a powerhouse in themselves itself. So to make them understand a neurological disorder, like for example, a psychiatrist only sees depression, anxiety, bipolar, other things. For them to understand MS, for me, it took time. So we need to give that dedication for them to understand. So when we are going to set up a clinic, it's about patients, it's about educating others, so that all of them are in the same page and we give the whole holistic, comprehensive care for a patient. So for now we have this. Apart from that, we also have a lot of checklists. We also have a lot of manuals for people so that even those manuals they can take and they can read and they can understand by themselves. So we have set up all these manuals from each of the specialty as well as a checklist for different medications. And there's a separate checklist for a pregnancy planning also. Thank you.
Thank you, Netra. Dr. Rajesh, so, you recently have encountered a very funny problem that, the same thing when we're talking about insurance stuff, there is one patient who got admitted with optic neuritis. He received the pulse therapy. And then, we started the DMT. And then the insurance rejected it. So this guy was admitted, he received this 5-day pulse therapy, and the insurance, the rejection was on the basis that optic neuritis patient should have been seen first by an ophthalmologist. And this was written. So then I flew into a rage. I seriously, I just said, this is from where did this come from? And then recently, Rohit and Dr. Rohit Saxena from the Indian Neuro-Ophthalmic Association, last Sunday we had a meeting to develop national guidelines for optic neuritis diagnosis and management. Now, how do we actually get this referral pathways? How do we standardize it? Because a lot of the MS, I would actually call them the children with MS because, they're so young. And then, I'm not a pediatric MS, so they go there into ophthalmology, then they go somewhere else, and mostly the ophthalmology, in fact. And optic neuritis as a first thing, and then there are a lot of people then they are lost. Or they come up to you at a stage where it is well advanced into several other things. And then we also have a neuro-opthal in the middle. So there was, in fact, in that meeting, the neuro-opthal said, okay, how many neurologists are there? So we said we are around probably 4,000 now in the country. They said, opthal, we are 25,000. So optic neuritis, and then you just give us a protocol, we'll manage. So you see, the issue here is, how do we standardize a referral system that people are now not lost in translation?
Yeah. So about the insurance aspect, I can still remember a case long time back when the insurance medical officer said that optic neuritis is a disease of the eye and not disease of the brain. And he said that your limit is 10,000, you can't get more than that. That is the level of understanding that people have about the human anatomy. So one thing is we need to demark who treats what. So ophthalmologists might give a course of steroids and stop at that point of time, but this is a disease which is going to come back again and again. So unless we have a clear understanding of what the disease is, whether it's MS or something else, we don't have any headways here. So one thing is to educate the ophthalmologists. I think the neuro-ophthalmologists and as neurologists, we need to educate ophthalmologists that, this is not your disease, this is our disease. We manage it better than you because it's not one-time treatment, it's a long-term treatment. Of course, we'll send the patient to you for OCT and other things. Secondly, to the insurance, patients also should be made aware of this. They should know that who is going to treat what. So many people come with varicose veins to the neurologist. In Kannada, this is called as Nara Roga. All that, anything nerve, veins are called as Nara and they end up with the neurologist. We have to tell them that, this is not nerve problem, it's a varicose vein. You have to meet the vascular surgeon. Similarly, patients have to be made aware that, okay, this disease is under this specialty. That requires a general education process right from their younger age. For the insurance purpose, a drug like rituximab is not usually cleared because the company says that it is not FDA approved. And I am not sure why in India we need a FDA approval for a medicine to be granted insurance. So they deny rituximab, but they're okay to give ocrelizumab. It's really stupid of the insurance companies.
Right. So, Praveen, coming to you. So you have a very, very successful practice which is going on for years now, and you see a lot of MS patients. So you have a huge setup. So do you have the space and also wherewithal? Are you running the MS clinic? And also, I would actually come back to you with as a corollary of what Dr. Rajesh already said. Is there a way that we can define and design a standardized referral protocol which can be actually given to the MSSI and to just harmonize that when you're talking about 12,000 patients there and you're 4,500 patients in a registry, and I'm sure it is doubled as 12,000 who are somewhere else, who are lost, and then they come with a disability, and then there is a hopelessness, and then we have an age limit, we also have a disability limit, and we have an infections and disability limit where you can't just go any further in terms of trying to manage. There is hope always, but the hope diminishes. So how do we prevent that?
So 3 things, ma'am. I'll answer from the referral thing. See, referral is not about, say, MSSI or some body telling somebody what to do. If we try to do, the referral will never happen. Right? Referral is about having synergy between people in a place. Now, you cannot have a referral standardization across the country unless the country has uniform healthcare policy, which doesn't exist and which is unlikely to exist in near future. Now, suppose I have to build a referral practice or Pravar has to build a referral practice, then it is the synergy between the ophthalmologist of my city, because they are the people who are going to send it to me, and me or the neurologist of my city, which will lead to a standardized referral practice. It is the understanding between them and us that if this is a patient, I will do this part of the job, this guy will do this part of the job better, and once my time comes, he is happy to send it to me back, then only a referral practice is built. For example, a ex guy in periphery sends me an optic neuritis, I see him, I send him to the ophthalmologist of Fortis hospital, he will never send me a patient again. Right? See, it may sound very simple, it may sound like this, but referral practice requires immense practical synergies for it to happen. We have a decent referral practice where people know that if this happens, I will do this, this guy will do this, this will come back to me, so it will work very well. So if ophthalmologists start referring optic neuritis to neurologists, it is a boon for MS patients, because that is the way to catch them the earliest, to treat them the earliest, and to treat them in what is the golden period of MS. So this can be done, it can be done, but it requires synergy between people rather than a policy, because policy cannot happen in our country. Second thing, coming back to insurance. Insurance is something that you have to learn to deal with in a specific way, because insurance has its own nuances and it has way of not giving the money. See, when you take insurance, insurance says do this, I will give you the money. When you file for insurance, it will say, why should I give you the money? So you have to learn to talk to insurance on giving you the money. And specifically for rituximab, because Rajesh raised a very, very relevant point, because a large amount of refusal is for solumedrol and rituximab. If together here we formulate a policy which is conveyed to the insurance that rituximab in our country is an acceptable treatment, not the FDA approved treatment for MS, but currently by neurologists of this country, rituximab is an acceptable treatment for MS, then insurance will have no way but to approve it. Today insurance denies rituximab on the ground of monoclonal antibodies, which are part of their policy document. So the guy, when he is buying the policy document, he doesn't understand कि नीचे उसमें एक line लिखा है which says that I will not pay for monoclonal antibodies. He has to ensure that he buys a policy which does not have this line. Once he is able to do it, he will overcome the insurance barrier. Third thing, as far as setting up MS clinics is concerned, see, one, no hospital has free space, because in a hospital as large as ours, which looks like an airport sometimes, still there is no free space. Second thing is, Setting up a MS clinic has many logistic issues. Logistic issues means I have a person who comes to the clinic. In a place like ours, a proper private practice, no reimbursement place. The psychiatrist sees him, the psychologist sees him, the rehab guy sees him, I see him. 4 people see him. The question in clinic is, who does he pay for? And what does he pay for? Realistic question, right? If I am not able to standardize the pathway where the returns from the clinic go to all stakeholders, then even if I establish that clinic, the clinic will not last. So if I get in my hospital, I have all the people that are required, right? Except for maybe the social worker, but that's not the big issue, right? So all the people are there. They are there at that point of time when the patient walks in. But if I were to get them to come to a specific space and work, I need to ensure that the returns from the clinic are equally distributed to all those people. That time is well utilized and distributed, because everybody's time is of value. I cannot have one person sit for 2 hours just to see or do one job. I will have to collect people to do a job for that clinic to become practically possible. So I really think that to do it is possible if we are able to actually translate idealistic considerations to real-time practical considerations which look after patients' interests, the hospital interests, and the physicians and the specialist interests.
Yeah, I think very well said. Praveen, that's when I talked about health equity is concerned. Now, there are countries in the world where there is equity, for whatever be the reason. Now, there are countries which there is no equity still. And we do have MS clinics which are well established in most of the countries where there is equity, or there is a near comparable equity, or other ways to address those situations. So in that, say for example, you take Canada or some of the European countries that you have, that you are not born and then think about what would happen if there is a problem. So there is an inbuilt infrastructure where there is an MS. So the whole thing is where you have an MS, then you go there and the MS clinics is already built in, depending upon the percentage of people who, in that region you have that many neurologists. And classically in MS clinic, you have an MS specialist and you also have a neurologist working along with that. And then you have all these things. And then there is, as Praveen said, if someone has gone in, then it is a full 2-3 hours of stay there, thrown in to some leisure as well as something to eat, everything. The ambience and the ecosystem is such that it is making the person comfortable. Now that is definitely a luxury. And if you can give that luxury in of the private settings, we do not have an equity which covers that kind of private setting. So there is a pragmatic approach will be very difficult here. Said that though, we had similar issues even for stroke management. At one point of time, the biggest killer is still stroke, and we did not have an equity even in stroke management. People are dying not just around big hospitals, they do in Timbuktu where there's nothing there. And India has a 3-tier system of healthcare delivery. There is primary, secondary and tertiary. The primary, you do just have a more of a preventive module. You may pick up and then you have to refer even the commonest of the ailments, whether it is cardio, neuro, gastro, whatever, what have you, the entire system. So there you have vaccinations, you have maternal child health, and you probably have preventive programs. But problems are happening there. And then you have the secondary, where the district level, where we had concentrated on the stroke. When Meenakshi, and we did this. We did work with the government, and now you do have in states at the district level, you do have free treatment. At least it is possible, it's happening. And you do have a CT, which is a plain CT as your workhorse, and that management, which was at one point not possible at all at these levels, and those strokes, by the time they come in, they're all, half of them are disabled because nothing can be done, is being done. So I think if you really have to think right with the associations, because the strongest voice is an association, because I've seen that voices happening with the muscular dystrophy. That happen, when the voice is the autism, that when the voices are strong, you can make a difference. And I think that kind of a thing, which is a pragmatic, practical approach of a win-win situation where nobody is a loser, and still be able to do it, I think we can do it. So we need to design that. You wanted to say something?
I just wanted to, actually I'm literally thinking aloud, listening to all of you, and particularly to Dr. Praveen Gupta and what he said. First, the dream that Dr. Pravar Passi said, and the practical aspect of what Dr. Praveen Gupta pointed out. And I think that we as an organization should be able to make an appeal. See, we do get CSR help. We have got some excellent CSR opportunities, and sometimes we find that we are actually under-equipped to handle the kind of CSR that we are even able to get. So what we would love to propose to all of you, because all of you are between private and the government office, like you have a Rotary in the oncology of AIMS. Why can't we have an embedded CSR HDFC MS clinic in Fortis Hospital? Why can't we have Infosys MS clinic in at Apollo, or at somewhere else? So would that be a possibility?
So no, I'll come to that, Praveen. The thing is that, whatever be the modem of, this also should be sustainable and scalable, because whatever you start off need also to, this many numbers, and it has to sustain in that level and also scale up. Now we have seen that, and I'm just drawing parallels to what acute stroke program that, I had initiated long back. And in April 2014, when this program was started in Himachal, and then it had to sustain and scale up to other states. And some of the states, it's actually gone down. So the thrust is not just money. The economy is one aspect, and that whole trailblaze which happens with once the money is provided is also a different thing. I think the impetus, but somewhere the beginning is great. I mean, that one can look into it and look at that possibility as well. But I think money alone is not the sole game changer. It is a whole lot of other things, and when it comes to a public sector, money is never the only thing. Even if somebody wants to donate something, Manjari would bear with me on that. Money, somebody wants to donate also, there are a whole lot of other things that go into in a public sector, where is it coming, how is it going, and this whole lot of chain which needs to be legalized and above board, and those kind of stuff. So, but then that's a great thought, we can look at it. You want to add something, Praveen?
Because what you say, in a private sector, it is a very, very relevant possibility of doing it, because once you have a CSR, you can actually take out a lot of considerations of the problems that I told you. Now we have the dream with us, we have the desire with us, we have the people with us. We need the binding force to make that happen, and with that kind of stuff, so to have a HDFC MS clinic done in one place and become a hallmark or a trailblazer of another clinic somewhere else is a very realistic idea. And I'm sure we can all together make it happen.
Yeah, but again, and I'll come to, I have another question for Dr. Mukul Varma. But then remember that, what we're talking about is clinics as they function not just in major hospitals or in metros. As I told you, the first case scenario which I've talked about is a 2-tier and, going down into to probably the district level. So we need actually the care and that kind of thing coming down there, because transport of a person who's disabled to come down to these big cities itself is a challenge. When we talked about referrals and MS clinics is to go down to may not be Timbuktu, but at least to the level of, say, Indore, or to even Bhopal, and there are whole big states where MS clinics are not there. And Delhi, Mumbai, Chennai, these are very well covered. Bangalore is very well covered. I would actually want these things to come up in those places and those states where the movement is extremely at a snail pace. Now I'll come down to Dr. Mukul Varma. Now, MS clinics is a dream for most of us. Hopefully we will see more movement now with new propositions coming up. But you're sitting there, you don't have too many people. But as a neurologist and an MS specialist, can you actually give some checklist and very easy to do things as a lifestyle modification which can encompass a lot of other things that MS clinic can provide?
Thank you. That's a very relevant question, and in fact, this advice is pertinent for every aspect of life, in fact. And I keep telling my family, sometimes I write on the family group, the 4 things that you need to do to live long. And so I think they are very similar. So one is no addictions. So don't smoke and don't drink and other addictions. Number 2 is a healthy, balanced diet. So basically have more protein, less sugar, a little less salt for MS patients, and less fat. And the third is, avoid processed foods and things which have aspartame and stuff like that. The third is regular exercise. This is working for every aspect of life, in fact. So it's a no-brainer. And the fourth, which I keep telling them, which we all ignore, is drive carefully. Yeah, yes, I was coming to that. A good sleep is absolutely necessary. About 7-8 hours of sleep, that will really do the job. And then coming to the mental aspect, the social aspect, because the person who is suffering needs to get family support. So you have to counsel the caregivers and the family members that they have to be sympathetic towards the person. They should, I keep telling, if there is a lady, the other way around also, I tell the spouse that, do you know the Gayatri Mantra? And they say, yes, I know. So I say, forget it. And there's another mantra which you have to tell your wife every morning. He says, what is that? As you have to tell her that you love her and you can't live without her. So it's a big laugh, and basically these are simple things. Thank you for asking such a simple question, and I think that covers it all in the lifestyle modifications.
Thank you. So in MS clinic, the whole idea of an MS clinic as such is to have this holistic approach to make a person who's living with MS feel better and live better. So there are the aspects probably will be still very difficult, except in certain big public sectors that you have straight away you can go to another, a room and consult a urologist or something. This is the last question though, so no problem. But there's one thing that as neurologists we probably can offer in an MS clinic, beyond talking about the therapeutic strategies, whether it's high end, low end, whatever we have, is addressing the mental health. And without getting into psychiatry and clinical psychology and and those battery of tests. So in that, and we also know the mental health aspects is not always the cognitive or personality changes which is inherently there in multiple sclerosis itself or the other demyelinating pathologies, or because of the medications. It's also the life's challenge that they are exposed to, including the other challenges, whether in terms of career, pregnancy, and a whole lot of stuff, and dealing with this big this like a bomb which that struck that, good God, what has happened. So in that situation, I want just 2 liners from each one of you as to how do you address the mental health issues with these, whether it's young or old, whoever is coming with multiple sclerosis, starting with you, Dr. Rajesh.
Yeah, so what people need to realize is that the quality of life is not in the body, it's in the mind. So when we sleep, it's absolutely fine, you don't know what's happening. The moment you wake up with all the worries and disabilities. So one thing to understand is that disabilities are for the body and not for the mind. So we need to segregate the mind from the body. It's called mind-body medicine. And we need to learn a lot from people who have served the army and have had various types of accidents. And I go to a place in rural India where I see army men with disabilities bring their relatives. Will feel that this guy is the patient. He is very happy about what he has or what he doesn't have, but he brings somebody with more other problems, and he takes care of that in spite of all his disabilities. So it's important that people learn to accept their disabilities and live with that cheerfully, see what best you can do with whatever disabilities. So improve the state of your mind, do regular meditation, be little spiritual in your life. Nothing is going to be permanent, it's going to change. Let's live with that philosophy, things will get better.
So I like to tell them not to focus on their illness, focus on other things in their life. And especially I like to encourage them to take up some hobby, something which they always wanted to do, and immerse themselves in it. And I think it really works well for them.
So, none of my prescriptions is complete without a discussion about exercise. I just feel all medicines on one side and exercise alone on one side is equivalent. Probably it even beats all our DMTs put together. You feel energetic, your dopamine is high, your spasticity becomes less, you sleep better, your weight becomes better, you have better sex, osteoporosis becomes less, everything becomes better with exercise. So I always tell them that exercise is a must, and you can swim, you can walk, you can dance, you do yoga, whatever, but exercise is a must. Rest, everything is negotiable.
What we have to do is to think beyond DMTs. See, we think and talk about DMTs so much that a lot of time we spend with patients about DMTs and medication. Second thing is, different patients will have different needs. We cannot apply one formula to everybody. So we would say that we will try and understand what are your needs, your mental needs, your lifestyle needs, and how can we help you fulfill those needs to get there. Right? Everybody has a different need, identify and try and help him fulfill it.
Lot of concept is now about positive brain health. So what we should remember is, for a positive brain health, there are 4 aspects: physical, mental, social, as well as spiritual. So all 4 are important for a proper and good mental health. So we have a physical disability because of some neurological disorder does not mean that we do not concentrate on the others. Having a good mental health, being with a person whom you love, is very important. Many times we want validation from somebody else who doesn't even know you, but we don't give validation from our own people. So a good emotional, mental health among the people whom you love, having a good social life, very, very important. I may be a highly skilled professional doing a lot of things, but if I don't have a social activity, naturally my brain is not going to work well. So social life is also important, and spiritual. So everything is a culmination in life. Thank you.
Yeah, so I'll just end by these 2 aspects to it. I have a patient with autism, and this child is now 15 years old, and he also had a lot of seizures, and a driven mother. The channel of energy in this child is actually art. And so this was channelized. It was not spent in trying into conventional education, learn mathematics. No. He sort of put his energy into colors. And believe me, ladies and gentlemen, his paintings are being sold in London. This boy is earning much more than the mother. Now, I'm just saying this, that you find your niche and the channel. There is a disability. This child is not into a societal norm, integrated into so-called conventional society of ours, but is probably in his own world, but doing well. And there is another book which has been recently published by a neurosurgeon who talked about Shen medicine, and this is a neurosurgeon from the US. Shen medicine is entirely dealing with the spiritual aspect, the nutrition, exercise, and spirituality. And this is by the neurosurgeon who was dealing with GBMs and operating on them. We have our own spiritual, the wealth with us. We have our own yoga. We have our own the scriptures. So I think it is time to fall back on the other energy levels as well, and help us holistically. This whole concept of an MS clinic is trying to holistically energize everything into one being to be able to make betterment in the living. Thank you so much.